So ethical and legal issues, everyone. I know there were already some very, very strong debates in the group. It's actually nice to see that everyone's getting heated in their discussions. But let's go through the ethical and legal issues, some of the concepts that you will get in the exam. So number one, the mental capacity assessment. Number two, DNA CPR issues. And to a very much lesser extent, the Mental Health Act. So in terms of ethical and legal issues, the Mental Capacity Act of 2005. And these 4 points, you need to learn them. There is no other way around it, okay? You need to understand the 4 points of the Mental Capacity Act. If any of these 4 points are breached or have been compromised, then the patient has no mental capacity. So any of the 4 points, okay? So they cannot consent and should be treated in his or her best interest. Do you all know about the presumption of mental capacity?
Everybody has mental capacity.
Yeah. So all patients are presumed to have mental capacity unless proven otherwise. When I started psychiatry, I went to my supervisor. We have like weekly supervision sessions, and I was like, Dr. Carr, I'm taking an hour and a half to clerk all these psychiatry patients. Do you have any advice for me? And at the end of whatever he was talking about, we ended up on the issue of mental capacity. And he asked me, why are you assessing everyone for mental capacity? All you need to do is, you need to put one line on your clerking document, or when you're documenting, say, I have no reason to doubt that the presumption of mental capacity is false. And that's it. So that saved me a lot of time in my psychiatric assessment, because I don't now assess everyone's mental capacity.
There is a question, are patients under 16 are also presumed to have capacity?
It depends if they're Gillick competent. Now that is going down a different rabbit hole. Forget about that. This exam is adult patients only. Okay, you will not have someone who's 16 and below in the exam. It's 18 and above.
Hallelujah.
It's adult patients only. Okay, so that's Gillick competence. That's a whole different issue. Okay, so coming back to mental capacity, you don't always need to ask these specific questions, or you don't always need to make it obvious that you're assessing someone for mental capacity. You can often just do it with a simple conversation. So someone without mental capacity to make decisions is often very obvious. You will note that there's something not quite right with them. Maybe they're a bit slow, maybe their concentration is off, maybe they can't quite remember what you're telling them, okay? And if you pick up on any of those, then you should do a formal assessment of capacity. In your exam, this will usually be a patient that has capacity and who wants to self-discharge. Now, this is fairly often, you see this fairly often in real life. You know, patients are upset with the NHS, I want to go home, I'm leaving home right now. Now, usually in real life, if you tell them, if you go home right now, you won't go home with any medications, they change their mind and say, oh, I'll wait. But in the exam, if the patient is angry and upset with you and says they want to go home, or they don't want to have surgery, or they don't want to have a colonoscopy, you have to test the capacity. Does anyone know how to do that? So just say I am a 56-year-old lady. I had a few episodes of rectal bleeding, and a few episodes of melena as well, presented with abdominal pain and loss of weight, and my GP put me on the 2-week fast-track cancer referral pathway, and I need to go for a colonoscopy. I don't want to have it. What do you do?
First, I'd ask them why, just to explore their reasons.
Mhm.
And then probably, once you get that information, ask them if they know what exactly a colonoscopy entails, to see if they understand what the procedure is or what the purpose of it is.
Mhm.
And I guess go from there, because if they don't understand what it is, you could explain it to them and then ask them to repeat it to you, because that's part of the, capacity as well, to see whether or not they can repeat back everything to you and whether or not they truly understand it. I guess I'd start there.
Yeah, that's basically what you do in the station. Okay, you explore the reason why they're refusing, you explain what it is, and you ask them, can you explain back to me what I've just told you? Based on everything that we've discussed, can you weigh up the risk and benefit of not going versus going for this procedure? So what will happen if you go for it? What will happen if you don't go for it? And then ask them to communicate their decision. That's what mental capacity is about. Yeah, it's someone who can make their own decisions. They can weigh up the positives and the negatives and use information to make an informed decision. So sometimes the case is very clear. Sometimes in patients who are psychotic, it's very clear they don't have capacity. Or for example, the elderly patient with delirium who's screaming that he wants to go home, but he clearly doesn't have any mental capacity to make that decision for himself. And others, it's not that clear. So patients might have slightly delayed responses, and you pick up on that. And then you have to do a formal assessment. So you spend a bit more time. So if the case isn't clear, so in the exam, always involve a senior, especially in a patient who wants to self-discharge. Okay, that's a safe thing to do. It's safety netting, and that's what they want to see from you. Okay, that you're safe, F1. If your senior isn't able to help, what can you do? So if you think the patient doesn't have capacity, your senior isn't sure if the patient has capacity or not, what will happen next? What can your senior do? What
Psych
can you
referral?
do?
Do you go for adults?
Referral?
Deprivation of liberty and safeguards?
No, so it's a psychiatric referral because psychiatry can do formal tests of mental capacity. It's a whole big performer. So I think the liaison team are very good at assessing mental capacity. In my geriatrics rotation, when we weren't quite sure or if there was a particularly disruptive family, and they were insisting that the patient would be discharged, and the consultant was just, I know these things are medical decision anyway, but sometimes you have to be a bit political in the situation. So my consultant used to just tell me, just refer to psychiatry and ask them to come and do a capacity assessment. And it's not a psychiatry doctor, it's not a registrar or consultant, it's a senior nurse, senior psychiatry nurse that comes and does the assessment.
We don't have to mention that, though. We would just mention that we're going to refer them to psych for a formal capacity assessment.
Yeah, but okay. only if the examiner asks you.
Okay.
Would you, sorry, on the note of deprivation of liberty, is that something that we can do? And if, for instance, you've got a very confused elderly who broke his hip and needs surgery, but clearly has no capacity, would you do a deprivation of liberty?
Different rules are different in different trusts. As an F1, I definitely did lots and lots of DOLS paperwork. I'm not sure at UHNM because I've not worked at the main hospital yet.
But you can do it, as a junior, as an F1?
I'm not sure about the legalities.
Okay.
I'm not sure if an F1 with a provisional registration can legally do it.
Okay, all right.
So
I don't know.
My F1 was a DGH, anything went there.
Okay.
I would assume that it's just not a decision that we can make. I mean, you said, you can fill out the paperwork, but the decision ultimately would lie with whoever does that formal assessment.
So I've made those decisions before. Like an elderly patient has fractured their hip. They're clearly delirious. They have no capacity. So I used to just sign and fill out the DOLS and the Mental Capacity Act and put it with the DNAR that I had also signed. But like I said, do not do this. Do not do these things in real life, okay? Most of when I worked and did these things were under exceptional circumstances during COVID, and we were really short-staffed. We didn't really have any F2s. In terms of the exam, I would always make it clear that you would involve your team and involve a senior before making any of these decisions. That includes, so in the mental capacity station, mention involving a senior, DNAR, involve a senior, DOLS, involve a senior. Okay?
No more questions in the chat.
Okay. So at the end of this capacity station, the examiner will usually ask you to explain your decision and how you came to it. Yeah, that can be a range of questions, but it usually comes back to you just mentioning the Mental Capacity Act of 2005, the 4 points that I've given you in the previous slide, and asking you to rationalize your decision. So a bit like the handover station, yeah, but to rationalize why you've come to a certain decision. And always mention involvement of a senior in these ethical and legal issues stations.
Somebody's asking if you can explain DOLS.
DOLS means deprivation of liberty standards, and I haven't included it here, but you can mention it to your examiner, but if you mention it, they might ask you to explain it. It's a piece of paperwork or a piece of legislation that deprives someone of their liberty. So deprives them of the ability to make their own decisions because they do not have the capacity to do so. Under a DOLS assessment, so under the DOLS piece of paperwork that we had to fill out, it's usually a piece of paperwork that comes from the council. So when I did it, it was Walsall Council. And I had to clarify why I was asking for DOLS to be put in place and what I wanted the DOLS to be put in place for. So medical management, because the patient can't consent to medical management, nursing assessment, important for nurses, and any other decisions related to the further management, including discharge, destination of the patient. Okay, I wouldn't go too in-depth about DOLS. I would focus on mental capacity. I don't think even in PLAB 2 they ask you about DOLS.
No, I don't think we got asked that. I mean, not any cases that I had, at least.
No, so it's more of something that just like a kind of a legal thing. Yeah, so you fill out your mental capacity paperwork, do your DOLS paperwork, and you put it all in that nice little sleeve with the DNAR in your red form, and you put it in the patient's notes. Okay.
No further questions?
Okay, good to go.
This is kind of repeated here. If a patient is at risk of doing harm to themselves or to others, one of the options is to detain them under a section of the Mental Health Act. I'll go through some of the sections of the Mental Health Act later on, but the most important section for a doctor working in any other area other than psychiatry is Section 5.2. Okay, under Section 5.2, it's detention for up to 72 hours until a senior psychiatrist or the senior psychiatry team comes to review. FY1s cannot fill out Section 5.2s only because of the provisional registration. Okay, that's the reason why F1s, at least here, don't do psychiatry on calls, because at night, 2 a.m. patients decide they want to go home, and sometimes you have to do a 5.2 to keep them until the next day. Okay. So just by the way, can someone have mental capacity but still meet the criteria for detention under the Mental Health Act?
Definitely.
Yeah. I had actually, when I took my PLAB 2, one of the cases was a patient that was suicidal, and he was also a pharmacist. So one of the pieces of information that, was revealed throughout the interview was that he had access to the exact medications that could, help him follow through with a suicide attempt. So one of the things we discussed, or I asked him that, if he was interested and we could keep him at the hospital for his own safeguarding to prevent him from, potentially following through with another suicide attempt. I didn't exactly mention that, we would be detaining him under the Mental Health Act, but it was just something that I mentioned if he was interested in, we could keep him in the hospital for his own safety. And that was actually something the patient agreed to. He said he would want that. So, I mean, I don't know if, this specifically relevant to this, but this was a scenario that I dealt with on my PLAB 2 exam that the patient was open to and wanted, was to be held at the hospital for, psychiatry review and, for his own safeguarding.
Yeah, so that's a really, really good scenario, and you absolutely did the right thing. So the first thing you do is you offer them, say, we can help you, okay? And if you can stay here with us, we have a really lovely, lovely team. Just stay here with us for a little while, and we can end up helping you. If they refuse, and if they still insist that they want to go home, then you can stay. And if they keep refusing to stay in, then that's a trigger in the station for mentioning the Section 5.2 under the Mental Health Act. So then you have to say, I don't want to do this, but for your own safety, because I think your mental health is not stable. And if I allow you to go home, or if we allow you to go home, it could be potentially dangerous to you. Then you mention detention under the Mental Health Act. And the reason why you have to mention detention is because they have a reading of rights. So someone comes out and reads them the whole rights. And that's why you have to mention detention. Someone can have mental capacity and lack the sufficient mental health to make a decision about their treatment and management. A good example of this is a patient with moderate to severe depression, like you mentioned in the case of the pharmacist. So they're generally very, very intelligent person. They can understand everything. They'll probably be able to tell you more about drugs than you know, but also that they have access to those drugs, lovely tricyclic antidepressants and benzodiazepines and things like that, which they can use. They will be able to explain everything about their condition. Yeah, they might even acknowledge that they are depressed, but they will be so depressed that they will insist on going home. And if they tell you outright, I had a patient like this on my nights. She wasn't a patient with depression. She was a patient with a personality disorder, emotionally unstable personality disorder. And I asked her outright, if I let you go home right now, will you kill yourself? And she said, yes. And this time I'll do it properly. Because I made the mistake last time of calling my care coordinator, and she called the ambulance. And the paramedics interrupted her suicide attempt. She was overdosing. So because she had told me that, I told her, I cannot let you go home. In any good conscience, my good conscience, I cannot let you go home. Okay? And that's a prompt for section under 5.2.
That was actually kind of how my scenario went too. I asked him as well, like, if you go home now, what do you think will happen? And he said kind of the same thing. I'm going to probably try again. And that's when I mentioned it's probably a good idea for you to stay here. And first I asked him if that was something he'd be okay with, which again, he fortunately agreed to. But if he hadn't agreed, then I guess it would have been worth mentioning that it's necessary to detain you under this Mental Health Act.
Yeah, it's very lucky that he agreed.
Yeah, definitely.
Would you just would you just say, I have to, for your own good, I'd have to detain you under the Mental Health Act? Would you have to mention that what you said, Mental Health Act 50, whatever?
So only if they refuse and keep refusing to stay in on an informal basis. The patient that I actually saw on my on-call, one of my on-calls on my nights, she had actually initially agreed to stay. So she took some of the pills. She had a partial overdose. She was admitted at the Royal Stoke. Then she was seen by the mental health liaison team and transferred over to Harplands. I saw her and I clocked her in at like 2 a.m. And at the time when I initially spoke to her, I asked her this question: if I let you go home, what will you do? Will you kill yourself? I didn't ask what will you do. I asked outright because I don't have that kind of time on the on-call. So sometimes I need to be a bit blunt and direct. So I asked her, if you go home right now, if I let you go home, will you kill yourself? She said, yes, this time I'll make sure I do it properly and I won't tell anyone. Obviously, I documented all of that. Then the nurses called me at 4 a.m. and said, can you please come and speak to this patient? Because she's screaming, she's kicking up a fuss, and she wants to go home. And then that's when I mentioned detention under the Mental Health Act. And it was such a pain to do because it was 4 a.m. But I would always mention it. Can you please stay? We can help you. We can find someone to talk with you. We can try some medications to maybe lift your mood. Say it again. Say it again. After 3 times, I would say detention under the Mental Health Act.
Right. Thank you.
Right. Okay, anything else?
Nope.
So DNA CPR. Everyone comfortable with this?
Yep.
Yep.
I think everyone might have a bit more knowledge about this now after the conversation and the discussion we've had on Telegram. So DNARs, so number one, it's the patient's choice to not be resuscitated, but it is not their choice to be resuscitated. So in other words, they cannot demand resuscitation. The best possible outcome and the best possible scenario is with the patient and their family and the healthcare provider coming to a joint decision for the best possible care of the patient. That's about 80% of what happens, but it doesn't always usually happen like that. If the patient lacks capacity, the clinician completing the order is the final decision maker. If the patient has capacity, the clinician completing the order still is the final decision maker. So basically, it is always a medical decision for DNAR. Right?
Yes.
They could potentially try and trick you with some scenarios. We'll go through a few scenarios at the end. Okay? An important thing to understand that patients and their families can deny treatment, but they cannot demand it. So if you have patients demanding antibiotics and chest x-rays and steroids and CT scans, they cannot do that, okay? They can refuse treatment. They can say, I don't want that at all, okay? I just want to be left alone. And if you think that they have that capacity to make that decision, that's fine, okay? Does anyone have any questions on DNAR?
Nothing on the chat.
Yeah, I think we pretty much discussed everything that we need to discuss in the Telegram group. The Mental Health Act. The Mental Health Act is so completely vast. There's so many sections. I don't even know how many sections. There's pages and pages of sections. I will just go through the absolute important ones on these pages. Yeah, so there's 2 pages. The one that I've bolded out is the one that you absolutely have to know. It's section 5.2. Okay, so 5 brackets 2. It's a detention of a patient who is already in hospital. When is a patient admitted to hospital? Or let me try and rephrase that. Is
when
a
they
patient,
need treatment.
yeah, so is a patient that is seen in A&E in hospital?
No.
No. So a patient who is in A&E is not technically and legally in hospital. For someone to be detained under Section 5.2 of the Mental Health Act, they need to be an admitted patient, and A&E doesn't constitute being admitted. So they need to be on AMU, they need to be on SAU, they need to be on any of the millions of wards, okay? They cannot be detained on a Section 5.2 in the community or in any public area. So not in A&E and not in the public domain. If they are, for example, on Ward 201 or Ward 123 or Ward 223, 223 is RESP, isn't it?
I think they've changed so many times during the
Okay.
year.
Well,
Lost it.
Okay. If they are, for example, on the respiratory ward, Ward 223, they're already admitted there, they were treated there, and they start to exhibit signs of psychosis for whatever reason, and they're demanding to go home. You can then detain them. Okay? Not in A&E. This is vital. It is illegal to put a Section 5.2 for a patient who's in A&E. And that Section 5.2 lasts up to 72 hours. Section 5.4 is very similar to Section 5.2. It's nurses that can detain a patient until a doctor reviews, and that lasts up to 6 hours. It's usually the most senior nurses, so like ward managers and site managers that do these. There's usually always a doctor on site or on call, so I've never really seen a Section 5.4 in real life. Section 4 is emergency treatment for up to 72 hours. And just coming back to the Section 5.2, the Section 5.2 doesn't mean that you can treat the patient. It just means detention. You cannot institute treatment on a Section 5.2. Definitely not any psychiatric treatment. The only type of treatment you can administer is emergency treatment. So 5.2 doesn't give you any rights for treatment of a patient. That's a different section. I hope no one's getting confused. I mean, it is very, very confusing. So just stop me at any point if you want me to skip the section entirely, because literally the only part you need to know is the Section 5.2.
But what section are you skipping?
All of the other ones. So I'll just go through them quickly, and then we can do scenarios.
Sorry, I have a question, if you don't mind.
Yeah.
So like in A&E then, if you have a patient who wants to go home but is suicidal, then how do you detain that patient, since you said we can use Section 5.2 in A&E? Yeah,
so there's 2 options there, right? So you can either admit the patient, so you can admit them to a ward, or the police can detain them on a Section 136.
Okay, thank you.
Is that for Section 5.2?
So if the patient is in A&E, yeah?
Yeah.
But they're, just say, exhibiting psychosis. Yeah. And you think, and everyone else thinks, or the A&E doctors think, that the patient should be admitted.
Yep.
You can't do a Section 5.2, but you can do another section. If the police are there, they might be able to do a Section 136. And there's 2 other sections. There's Section 2 and there's a Section 3. And there is the mental health liaison team has an area in A&E. So they are always there and they are always on site. They have the ability to come and do emergency assessments, mental health act assessments. Okay, so you don't need to worry about any of this. The psychiatry team will take care of this.
Right, thank you.
The line that is in bold, this part is all that you need to remember. Section 5.2. Section 17 is a community treatment. Section 136 is only for police, and the person must be arrested in a place which the public has access to. Section 135 is magistrate order. So just say if a patient is in their house, so the mental health team can apply for Section 135. The magistrate gives out the order, and then the police then go with the accompaniment of an AMP, so an approved mental health practitioner, to the patient's home, and then only they can remove them. So someone raised their hand. Says
Hi. Yeah. Hi. So, I was just wondering, with all the sections and compulsory detentions, I guess F1 is actually not allowed. So we will only say we'll refer, or we will ask our psychiatric colleague from the psychiatric ward. So we can't really mention, isn't it? Because we can't really we can't really detain them.
So what you can do is you can say, there is something under the Mental Health Act of 1983 called a Section 5.2, in which the team can detain you for your own safety if we need to. And this can last up to 72 hours. So make it very clear that the team is doing it and not you.
Okay. Yeah. Okay. Super. Thank you.
Literally do not have to know any of the other ones. Section 2 is admission for assessment, lasts up to 28 days. Section 3 is admission for treatment and lasts up to 6 months, and this is renewable. It's just there to just wrap everything up. You do not have to know it, okay? Section 5.2, just remember, learn it, Section 5.2.
No more questions.
Okay?
Okay.
Any questions at all? I mean,
No.
until we go to the scenarios.
Nothing on the chat.
Okay. So I have a few scenarios, and I've split the first one up into 2 parts. Does anyone want to have a crack at it?
I'll have a go if no one is.
Okay. The floor is yours.
Oh, okay. So wait, I need to read properly.
Can you read it out loud, please?
Yeah. Margaret Hollinshead is an 88-year-old female who has multiple medical comorbidities. On this occasion, she presents with decompensated heart failure, and despite maximal medical therapy, she continues to deteriorate. Her family have made it clear that they want everything done for Margaret, including resuscitation. Speak to the appropriate person regarding DNA CPR order. So when it says speak to the appropriate person, is it going to be like the consultant, or would it be the patient / the patient's family here?
That's part of the scenario.
Ah, okay. But what I'm asking is, like, when we have the Zoom call, is it going to be everyone, like 3? I don't know whether there's going to be 3 people, patient, family, consultant, and we choose one, or...
I honestly don't know how it is either, but I kind of structured the scenario in real life.
Okay.
So if you can imagine yourself on the wards, there's 6 people. There's Margaret's family, 6 people.
Yeah.
Yeah, her 2 sons are really tall, 6 feet, bruises, rugby players. Yeah. And you've got this little old lady in bed, and someone tells you, speak to them about DNAR. What do you do? Who do you speak to? And how do you go about the scenario?
Okay.
Would you need to ask among the family members whether any of them have LPA over her medical decisions?
Yeah, you can ask that. But what I'm kind of getting at is to try and speak to Margaret alone first.
Yeah.
Yeah.
Okay.
Because there's nothing to indicate here that she's confused. So it's heart failure. Yeah. So what you can do is, but intimidating in real life, go up to the family, go up to everyone there and say, could I please speak to Margaret in private?
And if they say no?
If they say no, ask them why, and then say, I'd like to speak to her in private first, but I can call you in at the end. And of course, if you have any questions, I'm more than happy to help. And usually 99% of the time, they comply.
Sorry, do we check if she has an advance directive beforehand?
You can ask her as part of the scenario.
Okay.
But that would be something we ask Margaret while we're talking to her.
Yes.
Okay. So she would be then the appropriate person to talk to regarding.
She would be the appropriate person because you want to put a DNA in for her. So she's the appropriate person to talk to. It's not her family. It's basically, it's not her family that I was trying to get at. So you don't talk to the family, even though the family is all around her at the same time.
Yeah.
Okay, so in this scenario, then how would we approach it? You know, first, like you said, we would ask if they're family present, could we speak to Margaret alone? Explain to them if they say no. And then when we were talking to Margaret, just kind of started off the way we would any other patient interview. Hey, you know, confirm her name and age. How are you doing?
Yeah.
See, you know, if she understands what's been going on, or explain to her what's been going on. And then ask her, I guess, or tell her that, you know, despite Max, like everything that we've done for her, her condition is deteriorating further. And now we would like to discuss with her something called a DNA CPR. Wait a moment and then ask her, do you know what a DNA CPR is, and explain it to her.
Yeah, that's exactly what the entire thing is. It's a communication station.
Okay, so obviously, in addition to telling her what DNA CPR stands for, would we have to then go into saying, all right, well, this is what CPR is, cardiopulmonary resuscitation, this is what it involves, these are the pros and cons, like the risks associated with it, and then tell her, I guess, I mean, it seems like in this situation, the doctors might be thinking that it is in her best interest to get a DNA CPR because they've already tried a lot. And then physically doing something like CPR could cause her more harm than good in terms of, you know, physical damage, breaking ribs and things like that. And it might not actually help her.
Sorry, I thought Diana was having a go.
No, I'm okay.
Sorry, I don't know who's talking.
No, don't worry, don't worry.
All right.
Just figured, you know, since we're discussing it.
Oh, so are we doing a scenario, or are we discussing it? Or?
I think that pretty much covered it. I don't know.
Yeah.
if you want to go through it, yeah, I'm happy to speak on it.
I think she's covered it, but hopefully, okay. So if I miss out anything, then please do feedback. Okay, so should I start?
Yeah.
Hello, my name is Dr. Han. I'm one of the junior doctors here. So is it possible? So who are you? Who are you here? Like, who's here at the moment?
So in the bed is Margaret Hollinshead. She's a little old lady. Around her 2 sons, her 2 daughter-in-laws, and her grandson.
Okay, so is it possible to talk to Margaret Hollinshead in private? What am I talking to the families?
Why do you want to do that? So this is the son. Why do you want to do that, doctor? You know, my mom is really old. She's really sick. Can't you talk to all of us at once?
So because this is, I would like to discuss about Miss Hollinshead and her condition and the plan of management. So I would preferably like to talk to Margaret in private. Is that okay? Or is there any reason that you would like to stay in.
Would you be able to explain to us afterwards, and can we ask any questions afterwards?
Of course. So if Margaret, you know, allows, well, first she will hear what I've got to tell her, and then if she wants to tell you, then I can definitely disclose and also answer all the questions that you may have in due course.
Yeah, that's fine.
Okay.
So we'll wait outside.
Okay, that's great. Okay, so hello, Margaret. Is it okay to call you Margaret or Miss Hollinshed?
Margaret is fine.
Okay, superb. Hi, Margaret. How are you doing today?
Not too bad, doctor. I mean, I feel a lot better than when I first came in.
Okay, that's good to hear. That's good to hear. And has anyone described you or explained to you anything about the treatment or your condition?
Well, I know that I have heart failure, and you know, my old ticker is getting on in years.
Okay. And what about any like medical treatments that you had in the past years? Do you remember anything, like any medications or anything like that?
Well, I'm on so many medications, doctor. I couldn't even tell you, even if I tried.
And how are you coping with everything in general?
Oh, the pharmacist that I go to is very nice. They put it in little pre-packaged packs, so I just have to pop each one out.
Okay, so Margaret, so I came to talk to you about, you know, your condition, but also what we're going to do from now on. And of course, you know, we do want you to get better and everything. However, we do also need to think about that time where if you know you do go into something called heart attack or something like that and you continue to deteriorate, then we do have to think about your end of life care. Is that okay, or has anyone mentioned about anything like this?
I haven't really given it any thought in the past, but now that you come to mention it, it's probably something I should be thinking of.
Okay. And have you talked to your families, or have you do you have any have you done anything called advanced directives or like a living will?
No, so I haven't thought about this in the past at all.
Okay, so it is a lot for you to take in at the moment. However, we do want to ask you if there is any, you know, any kind of advanced preference in how you want to be treated at the end, or how you don't want to be treated, and how the family should prepare for the whole event. So that's something that I do want to let you know. Have you heard anything about something called CPR before?
Isn't that what they do in the movies?
Okay, yeah, definitely. So it is something, CPR stands for cardiopulmonary resuscitation, and it means if a person dies of, or if a person has a cardiac arrest, so heart attack, or loses consciousness, there will be, so we are advised to do a cardiopulmonary resuscitation, so, you know, chest compression, try and bring people back. However, there are cases where even if you do the CPR on certain people, certain group of people, there's not it's not a clinically appropriate decision to do that. So in that case, we do not advise, and we do want, because that's it's not that we are giving up on the patient, but that's because we are weighing up whether there is more harms or more goods involved in that intervention. Does that make sense?
Yes, doctor, that does make sense.
Okay, yeah, so that's why, you know, in your case, what we feel is that because we've tried different interventions regarding medical medications, however, at the moment, your condition doesn't seem to improve. So even if we do CPR, there is not a likely chance of you getting better. And even if you do get better, we are worried about, you know, the quality of life you may have after that intervention. So what me and my consultants will be deciding is something called do not do not attempt CPR. And we will have this written as a form. And before we do write this form, we did want to come and talk to you about it. Is it okay?
Yeah, that's okay. I think I don't want to have my dignity taken away from me.
Yes. So, exactly, Margaret. So that is one of the reasons why we want to talk to the patient about it, because it is, you know, it is of utmost importance for us to also respect the end of life kind of, well, the last days of our patients, and, you know, try and preserve their dignity as much as possible. So if you have any questions regarding this, you can always come to me and ask away, or ask any of the colleagues. And is this something that you want to talk to your family alone, or?
I think I would like to mention it to my family.
Okay, so, you know, it will be quite hard, but if they do have any questions, then they can always come to me and do the same. Okay. Okay, super. Thank you. Okay.
It was very good. You explained everything. I think it was a bit long-winded.
Yeah, it was.
But it was good. How long did that take? Was anyone keeping account? But I think you had a lot of time at the end. So being long-winded isn't necessarily a bad thing.
Okay.
Yeah, because you have 9 minutes to talk. The patient might have a few questions, or they might not have any questions, which is the best type of question. Yeah, I would say, you know, Margaret, how are you feeling? And she might say, I'm all right, I'm getting a bit worse, I'm getting a bit breathless, I'm feeling a bit better. Have you thought about what will happen to you in the long term? And she will say, what do you mean? Well, Margaret, you're 88 years old. You have heart failure. And despite all the medical therapy that we've been giving you, you're probably on a lot of medication, which is unfortunately is not working. Okay? So you're continuing to deteriorate. Have you made any plans for the future? So she might say, well, in terms of what? What do you mean? What I'm trying to get at is, do you have a lasting power of attorney? She'll say, no. They will almost always say no. Okay. Do you have an advance directive? No, don't have any advance directive. I don't have any lasting power of attorney. Have you heard about something called CPR before? She'll say, yeah, I've seen it in the movies. Is that where they jump up and down on someone's chest and say, yes, that's exactly what it is. So CPR stands for cardiopulmonary resuscitation. And it's basically whenever someone's heart or lungs stop working, there are various maneuvers that medical team can do in order to restart them. Okay, and that can involve various things such as jumping up and down on the chest, as you rightly said. It can involve putting tubes down your throat and attaching you to oxygen or machine to help that the machine breathe for you. It can involve injecting you with some drugs to try and jumpstart your heart into working. Do you think at 88 years old, you would want something like that? She might say, oh, I'm not sure, you know, I don't want to die, or I want to live, or I want to see my grandchildren or my great-grandchildren. I say, absolutely, I absolutely understand that. And it's a very difficult situation that we're in. Obviously, we will continue treating you to the best of our abilities. But because you're 88, and because you're frail, and because your heart is already so damaged, it means that whatever type of maneuver that we do, or for however long we do CPR for, it is unlikely to work. And the longer the period that we try and restart your heart with jumping up and down in your chest, chest compressions, trying to push oxygen into your lungs, that's the length of time that there's not going to be enough oxygen going to your brain. And there's several outcomes in an unfavorable situation such as that. So it's very unlikely in the first place that your heart will be restarted because of your heart failure. Because you're frail, your ribs might fracture, and that could pierce your heart or your lungs and cause internal organ damage. If on the rare off chance that we do manage to restart your heart, because you were without oxygen for such a long period of time, you would likely end up brain dead. How do you feel about that? And then she would say, oh, you know what, I don't think I would want that, and yeah, but I still want to live. Then you would go on to say, it's not really a matter of you living, it's about dignity as well. So in an emergency situation, when someone's heart stops suddenly, or if their lungs stop suddenly, there's an emergency buzzer that's pulled. And when that happens, all the medical staff in the surrounding vicinity rushes to the area. Your chest will be laid out bare. We'll have people jumping up and down in your chest. There'll be a big machine that will deliver electrical shocks to you. There'll be people putting big needles into your arms. Honestly, in my opinion, I don't think that's the best thing for you at this time, okay? And it doesn't mean at all that a DNAR or a do not attempt cardiopulmonary resuscitation, which is essentially what I'm getting at, it doesn't mean that we're going to stop treating you, okay? So we're going to give you as much medication as we possibly can. We can give you oxygen. We can give you antibiotics if you get an infection. We can give you IV fluids if you need IV fluids, and we can give you all sorts of IV drugs to help you with your heart failure. Now, how do you feel? Then eventually the patient actor will agree, will say, okay, doctor, what else do I need to do? Then you will say, Margaret, there's nothing that you really need to do. As a courtesy, we like to involve patients and their families with these types of decisions, but DNAR decisions are medical decisions. However, if you have any questions, I'll be more than happy to answer any questions. What I will do after speaking to you is go out and ask one of my seniors. I'll tell one of my seniors that I've had this discussion with you. I'll document everything very clearly in your notes, and then the consultant will sign the DNAR form, which is a red form. And then you ask if she has any questions. She'll say no, and that's how you end the station. Okay?
At the end of a station like this, if we have time or maybe just something we can mention, would it be okay or beneficial to mention something like an advanced directive and lasting power of attorney, if that's something she hasn't already taken care of?
No. So at this point, with this particular patient, if she doesn't have an LPA, I would just go ahead and do the DNAR. Okay, so LPAs are usually done far in advance, not in situations like this where the patient is acutely unwell and deteriorating quickly and the decision needs to be made immediately.
Also, I noted I had two notes on your performance, Diane. So one was that maybe don't try not doing monologues. Try to ask more for the other person's engagement and try to do a dialogue. And then the other one was I would be careful with the term end of life, because she's not really end of life. We don't know that. She's just has heart failure and multiple comorbidities, and DNAR would be futile, but it doesn't mean necessarily that she's dying now. Sorry, those were my notes.
Oh, you take your notes. Any feedback on my performance?
You were great, Margaret.
Yeah, so end of life and DNA are two completely separate things. End of life is palliative pathway, or end of life pathways means that we can't do anything else. DNAR means we can do lots of things for them. Yes, just that they're not going to ITU and we're not going to resuscitate if they go into cardiac arrest. Just means if they do get really, really unwell, we'll make them end of life, leave them alone, let them pass away peacefully.
Sorry, Sarishka. Do we need to communicate the same to the family, like when we stopped speaking to the patient and then you're meeting family and they all looking at you and waiting for some information what you were talking about with their mom? So would you have to explain the same about the respect form, what it's all about to them as well?
Okay, so that's the next part of the scenario. That's okay. So
sorry, before we move on, there's a lot of like very lively conversation in the chat about if you don't agree with the DNAR, you can take it to court, like maybe for like personal. It was more like for personal knowledge rather than DCA, but it's like who is the final decision from, and if you're a patient and you're not agreeing, then what's going on there?
So if the patient doesn't agree,
Yeah, can you just Photoshop me the?
Can I just ask you as well? Do you have to explain the sorry, what's it called? The advance directive and the other thing to the patient, or will you just assume that they know about it? When you ask them, do you know about that, and they say no, do you have to explain that to them as well?
so you can ask, do you know what a lasting power of attorney is?
And if they say no, then do you have to explain it, or will they generally say yes?
You, do you know what a lasting power of attorney is?
It's a power of attorney that you give to somebody that in case something happens to me, then you have the power to make decisions on my behalf.
So most patients in the UK are pretty knowledgeable on these things. You can ask them, do you have a lasting power of attorney or an LPA, or do you have an advance directive?
Mm-hmm.
If they ask, what is that? Then you explain. If they don't ask, don't explain.
So what's an advance directive? That's from the patient.
Yeah, so advance directive is just all of these things that it's a set of instructions that they give in advance about decisions relating to their care and to their end of life.
Right, okay, thank you.
So for example, if they want to go to hospice instead of dying at home, or if they would be okay with dying in hospital. So basically setting up all those treatment things that they wish to have. So for example, if they are in the community and they really don't want to go to hospital, then that's an advance directive.
Yeah, and those are things that you can incorporate into the respect form as well. There's also a little box on the red DNAR form that you can write all these things in as well. The ideal situation is that everyone would have an advance directive so that, you know, healthcare providers always know what to do if someone gets sick, if someone old and frail gets really sick. But that's unfortunately it's not the case. So that's why we have to do DNARs in the hospital on the spot. Was there anything else in the chat?
No, it was mainly that who's the last call on the DNAR.
So if the patient doesn't agree with the DNAR,
yeah, what happens if they don't?
well, they are absolutely welcome to file an appeal in the courts, but the courts will never agree with them. It's happened before. So there are lots and lots of cases. So when I was in F1, I made a massive mistake with the DNAR. I won't tell you what exactly I did, but I got a bollocking from a consultant and he made me read up on DNAR. So, and I've done a lot of DNARs now, so I think I have a pretty good knowledge of it. There are two very famous cases. One is the Addenbrooke's case, and the other case I've actually forgotten. I might have logged it on my e-portfolio. I can share it with you in the group if you want. Basically, they're more than welcome to legally contest anything, but the courts will not agree, so the judge won't agree. It's always a medical decision. it just complicates things a bit. But once that DNAR is put in place and is signed, it's valid and it stays.
However, I understand that around the legislation, patients can seek for a second opinion. So, for example, if you sign the DNAR and they don't agree, they can still look for a second opinion, but that's usually unsuccessful because usually the second opinion would agree with the person that did the DNAR in the first place.
So they can always seek a second opinion. They usually go to the community, so the GP, but they can also ask for a second opinion from another consultant or the clinical director, very rarely the medical director, and then they can always take it up to the courts because everyone has a right to go to the courts if they feel that their rights are
Would you advise it though? So in this case, when Margaret says she's refusing the DNA CPR, would you say, well, you're within your rights to refuse it and that's understandable. You could have a second opinion. Would you advise it, or what would you say to that?
No, so what I'm getting at in the scenario is trying to focus more on communication issue. So bringing the family and the patient together and explaining to everyone just again what a DNAR is and making it very clear that it does not mean, because many patients don't know. So when they say, when they hear DNAR, they get very scared and they think, oh, you're just leaving me to die. That has to be very clear in part 2 of the scenario when you speak to the family and Margaret.
Right.
Thank you very much, but I have a question here. Can you explain how you would address this situation to the family? As I mean, Margaret said, you can talk to my family, or I would want you to talk to my family about DNAR. Can you explain how you would start a conversation with the family members now?
Okay, I can do it if you want.
Should we have them on a template this scenario?
If someone wants to be the family and someone wants to be Margaret, I can do it.
Sorry, just to be mindful of the time, it's 10 to 8. I don't know how you're doing, Shar.
It's all right. I budgeted time for up to 8 because I figured this would be really long and people would have a lot of questions. Tomorrow is my teaching day, so I'm at home tomorrow.
All right, yeah, as long as you're happy.
Okay. I'm happy to do this with someone. If someone's Margaret, some people are the family. So with the family, be angry at first.
Yeah.
But at the end, once I explain everything,
I'll be the family.
I can be Margaret.
So hi, my name is Shah. I'm the F2 on this board. How can I help you today?
Hi, doctor. Am I supposed to be frail? Okay, I heard something about DNAR, that they've put a DNAR on my name. I don't think that's right. I think you made a mistake.
So are you Margaret?
Yes, I'm Margaret.
Oh, okay. So I already spoken to you in the first part, but instead of accepting it, you refused it.
Okay.
Yeah, so okay, I'll just go into it. So Margaret, so I do understand. Do you remember the conversation we had a little while ago where I explained what CPR is and what a DNA CPR is?
Sorry, does Margaret has capacity?
Margaret has full mental capacity.
Okay. Yes, I remember what you said, doctor. I remember what you said about DNA CPR.
Have you had a chance to think about it or speak to your family?
Yes, I have. And I don't want it. I don't want a DNAR. I want to be resuscitated like you explained to me. I think I have my house to go to and my dogs, on all my farm animals on my beautiful farm. So I want to go home. I want to be alive.
And I quite agree with Mom. You know, she's only 88. You can't just like say we're gonna just let her die. You know, it's not fair on her. She's got, I mean, well, she can have like 1 year, 2, 10, we don't know. We're not going to just let her die.
Yeah, absolutely. If it's okay with Margaret, so Margaret, are you all right with me explaining everything to you and your family again?
Yes, that's fine. That's fine. We are all in agreement. We they all want me to go home. I like staying at home and being alive.
Okay, absolutely. So has anyone here from Margaret or the family know what DNAR is?
It just means that you're going to not do anything for her.
So that's not quite correct. So cardiopulmonary resuscitation is the process in whereby we restart a patient's heart and lungs or lungs if in the event they stop. And a DNAR is just an order that we put in to say that if a patient's heart or lungs stop working, we will not try and actively resuscitate. It doesn't mean in any way that we will leave Margaret to die. Okay, so Margaret, we will do absolutely everything that we can do for you in terms of medical management. That means we will give you medications, we will give you IV fluids, we'll give you antibiotics, we can give you as much oxygen as you want. We'll make sure that you're pain-free, and we'll keep you nice and comfy here on the ward with us.
Well, what if her heart stops then? That's it. Then we would give up. Done. That's it. She lived her life.
So, because Margaret is 88 years old, and I absolutely hear where you're coming from, that 88 is not that old. Yeah, she does have a lot to live for, and she's not necessarily going to die. But because she has severe heart failure, in the event that her heart or lungs stop working, no matter what we try to do in terms of resuscitation, the odds of us restarting are very, very, very low.
What are exactly the odds?
I'm not quite sure of the odds, but for an extremely fit athlete in the prime of their life, like an Olympic level athlete, CPR doesn't work all of the time. So if you can imagine, if you could put Margaret and an Olympic athlete side by side, and if an athlete has a low chance of revival with CPR, what do you think the chances of revival with Margaret will be?
Well, she runs around the dog, you know.
Yeah, and she can still do that. Absolutely, she can do that. Yeah. All I'm saying is that it's not in her best interest for us to do CPR. So it's about her dignity as well. Yeah.
What is the worst thing that can happen? Like if you try, I mean, why can you not try?
So if we try, there's a high possibility that her ribs could break. Now, if her ribs break and fracture, it could pierce her heart or her lungs and cause massive abdominal bleeding and intrathoracic bleeding.
Oh, okay. No, I didn't thought it was so aggressive.
It's quite a gory picture, and it's absolutely not something that we want for an 88-year-old lady with heart failure.
No, definitely I wouldn't want that for Mom either.
Yeah. The other thing is, because of her heart is so damaged as it is, if we try and restart her heart, the length of time that her brain will be without oxygen for could mean that in the extreme rare case that we do restart her heart or lungs, if she does be revived, she could basically come back with brain damage. So she'll never be the person that you knew her to be.
Oh, I don't want that.
Yeah.
Everyone's very happy with me working on the farm and being chirpy. Don't want vegetable.
Yeah, no, we've got enough in the farm, Mom.
The other outcome is, so that's two outcomes. The third outcome is she could be dependent on the oxygen machine for the rest of her life, and we would have to make a difficult decision later on to stop life support.
Wow, I had no idea really. What do you think, Mom?
Sounds like they made the right decision, I think.
Yeah, I quite agree.
Okay. So if you have any questions, I'm more than happy to answer them. I just want to reiterate that a DNAR does not mean that we will stop treating you. So Once we sign that form, we will continue treating you. We will treat you until you leave the hospital. We will treat you in the community, and we will treat you if you ever come back to hospital.
All right. Yeah, I'm quite happy with that.
All right. Okay, thank you.
Thank you.
Do it a little bit like that.
Fantastic, though. Thank you very much.
Okay, so any other questions? There's like so many things in the chat, 96 messages in the chat. I can't read out all of these messages.
No, the last 4 is the ones that I lost. Thanks for that discussion. Scenario's great.
Okay.
No, nothing much.
Okay, fantastic. So let's go on. How many scenarios do I have? 2 more, right? So my throat is really dry. Can someone else do the scenario?
Sure, I'll read it. Daniel Waterhead is a 42-year-old male who has advanced motor neuron disease. The palliative care team have been consulted and he's nearing the end of his life. A DNA CPR is in place and the team estimate that he has less than 2 weeks to live. Before leaving his bedside, he manages to type on his iPad, "I want to die," and you're the only one to see it. Speak to Daniel.
Does anyone want to try it?
I'll try it.
Yeah, so it's not really capacity assessment or DNAR. It's just the communication station and knowing something.
Okay. So hold on, just real quick. So he can't talk at all other than through his iPad, but I'm assuming in this scenario, would he be?
Yeah, just assume that he can talk for the purposes of this scenario.
Okay, all right.
Or is typing everything out.
Okay. Hello, Daniel. I'm Dr. Khan. I'm an F1 doctor. I just wanted to see how you're doing. How are you feeling today?
You know what, doctor? I really, really don't want to live.
I'm sorry to hear that. What's going on?
Well, look at me.
Well, I understand you have this advanced motor neuron disease and you are under the palliative care team because you're nearing the end of your life. And we do have a DNA CPR in place. Do you know what that is?
Yes, I've been told what it is by the palliative care nurse.
Okay, and do you know what that means then in terms of your treatment?
It means that only if my heart or lungs stop, then you won't resuscitate me, but you're still keeping me alive at the moment.
That's right. Now, I noticed earlier you had typed something onto your iPad. Can you tell me what that was and why?
I'm 42 and I'm bedbound. You know, can't you just give me some medication so that I can die?
Unfortunately, euthanasia, which is, the medical team assisting in, you ending your life, is not something that is legal in the UK. Mm-hmm. So that's not really something that we could do for you. We can take steps to help you be comfortable towards the end of your life, but actually ending your life is not something we could do.
Well, really, I'm going to die anyway in a matter of 2 weeks. You know what? I'd just rather do it on my own terms. I'm already on morphine. All you have to do is push the button for me.
Yeah, of course, I can understand that this is a very difficult situation for you. But again, I want to reiterate that us taking any steps towards helping you end of your life is not something that we are allowed to do legally. Mm-hmm. So, that isn't exactly anything we can help you with.
All right, that's great. That's all that I wanted to point out is the euthanasia being an illegal part.
Okay, and then what exactly could we even do for him in this situation if, he were to ask, or if obviously we want to be a bit comforting and say, this is what we can do, other, you know, additional like supportive measures.
We can say that if you are in distress, we can ask the palliative care team to come and have a look at your medications again. So if you're having excess secretions, we can give you something to help with that. If you're in pain, obviously we can give you medications for the pain. If you are in any type of agitation, or if your mouth is feeling dry, we can ask one of the care workers to come and do some mouth care for you, or we can prescribe you some mouth spray. I just wanted to, this is not realistically something that you will ever get on the exam, just to point out that assisted death is illegal in the UK. This actually happened to me. By the way, obviously all the names in all the scenarios have been changed, but this happened to me.
So would a station like this require pretty good knowledge of, you know, what the NHS does for palliative care, like you said, you know, for secretions or pain or anything like that?
I've got a little card. It's somewhere here. It's called palliative care prescribing. So I'll take a picture of that and I'll send it into the group. You don't need to know too much. You just need to know pain, secretions, and mouth care. Right, so the drugs are obviously morphine. It's hyoscine hydrobutyl for the secretions. It's midazolam for agitation, and it's one more drug I've forgotten, but I've put it on a little card. So what we used to do in elderly care is we were each given one of the cards, and whenever the consultant told us, so that patient is end of life, just prescribe the drugs, we'd take it, prescribe everything, and that's it. So a little card that we keep with us.
So these would be the anticipatory medications. I'm just looking at my notes now. The other one is for nausea and vomiting, haloperidol.
Sometimes haloperidol, and sometimes it's something else. It depends on where you are and what the local guidelines are. I know cyclizine. No, not cyclizine. One of the drugs we ran out of stock of, and then the pharmacist asked us to prescribe haloperidol, but now apparently there's a nationwide shortage of oral haloperidol as well. So it depends on local policy. So you just have to know for pain. So obviously pain is the most important thing. The patient cannot be left in pain. Okay, it's very cruel. Agitation. So palliative care patients, they're very agitated. They move around, they moan and groan in their sleep, and they grimace. So we give midazolam for that. And then secretions, especially patients with massive aspirations and chest conditions, COPD, sometimes heart failure, they have lots and lots of secretions. So we can give hyoscine for that. And we can also ask PT to do chest physio to just try and help them. We can also suction. Okay. Okay.
Okay.
Last scenario. So this is one of the scenarios I think I spoke about earlier, mental capacity versus mental health. Does anyone want to give it a go? Come on, any medical FY1s, AMU FY1s here? No one wants to give the last scenario a go. It's a mental capacity station. Come on.
Sarishka, can we just do this one thing? Because I know you must be busy anyway. Whether we can actually turn it around, you can be the FY2, FY1, so we can actually see how you perform that. Because I think you have this really clear manner of being so concise but detailed and just smashing it out in a time level, so we can time it and do that, because it's been very useful to hear your.
Has it been? I'm not quite sure if I'm meeting the time targets. What I do now is I just smash things out when I'm asking
It's naturally for you now.
because I don't have time.
Yeah.
On the on-calls to do lengthy, hi, how are you? Okay, I can do it.
Sorry, I mean, I wouldn't mind doing it, but I thought I'd just.
That's all right. Let's look.
I don't mind being Emma, so.
Emma Law is a 35-year-old female who has been admitted to AMU for nasogastric feeding. She has a history of depression and is refusing to eat. At night, she begins to scream that she wants to be discharged so that she can kill herself. Flashbacks. You are the medical FR1 covering AMU and have been bleeped by the nurses to talk to Emma, talk to the patient. Hi, my name is Surishka. I'm the F2 covering AMU. Can I please confirm your name and date of birth, please?
Yes, my name is Emma Law, and I was born 27 June 1985.
So what's been happening, Emma? The nurses have called me and said you've been kicking up a bit of a fuss. What's been happening?
I just don't want to eat anymore, and I just want to go home. Can I please go home?
Do you know why you're here?
Oh, well, they're apparently I've been feeling quite low, and I'm not safe to go back home, they say. But I can go home.
Yeah. So, Emma, you currently have a nasogastric tube in. So you have a tube going through your nose into your tummy. You want to go home with that?
I don't want that anymore. I don't need it.
Okay. So you told me your full name and your date of birth. Do you know what hospital this is?
Well, I think we are in, I'm not sure, in A&E.
Yeah. And what day of the week is it?
I think it's, is it Monday? It's Monday.
What time of day is it?
It's in the evening.
Yeah. Who's the ruling monarch?
I'm being silly questions now. It's the Queen, Elizabeth.
Yeah, that's all right. Just do a little orientation to figure out if you know where you are and why you're here. So you've answered the questions very well, so you know who you are and why you're here. Emma, you also have a history of an eating disorder. Is that right?
Well, I don't really think so, but my mom just forced me to be here right now, so I think I look all right.
Right. Tell me about your depression.
Well, I just feel like I need to lose more weight, and hence I've been very low. So I just want to, I don't want to eat this, and I don't want to have this feeding tubes. I'm not a baby.
Right. How long have you been here on AMU so far?
It's been way too long. I think it's been like a couple days now.
And how much do you weigh?
Well, I've been told that I weigh 40 kg, but my aim is to come down further.
So you've mentioned that you want a baby.
I want to
Sorry, what was that?
I mentioned I want to even weigh less than 40 kg.
You want to weigh less than 40 kg. I'm not quite sure that that's the best thing for you. Do you know the consequences of being underweight?
Not really. I mean, there's nothing wrong with being thin.
Right. Well, it's good to be healthy. Yeah. And health is what everyone aims for. Losing weight becomes unhealthy when you get below a certain weight for your height. Now, I'm not quite sure what your height is, but 40 kg for any type of female that is an adult is too low, right? You do have a history of depression, and I think it might be manifest of your depression as well as your eating disorder that you're feeling this way. Yeah. Now, you may not really want to be here with us, but we do believe that you getting nasogastric feeding is the best thing for you at this time. Are you with me so far?
Yeah, but I just feel like I just don't feel like that, if I have this feeding machine, I will just become more fat, and I just want to go home and kill myself.
Well, obviously I'm not going to let you do that, okay, because you've told me that you're going to let you go home and kill yourself, so therefore I now cannot let you go home. I just want to let you know and try to explain to you as well some of the consequences of a very low weight. So you start to lose your hair. You can get conditions such as osteoporosis or weakness of your bones. You can stop having your menses. You can have skin conditions, acne. Some of the more dangerous issues, electrolyte abnormalities, weakness, hypoglycemia, so a low blood sugar level, hypotension, which is a low blood pressure, and that can make you severely physically unwell. And the reason that we've put the nasogastric tube for you is because you're obviously refusing to eat orally. Now, when we start to feed patients who have not eaten for extended periods of time via nasogastric feeding, this can cause electrolyte imbalances in the body. So things like potassium, magnesium, and sometimes phosphate in the body go off. And that can be potentially dangerous, particularly for your heart. So that's another reason why I really think you should be staying with us here in the hospital, so that we can keep an eye on your electrolytes and keep an eye on the activity or electrical activity of your heart. How do you feel about that?
Well, you know what? It's my life and I just want to go home. So I'm just going to leave right now. So I don't think you can keep me and force me to be here.
Right, Emma. So you absolutely understand where you are and why you're here. And I do believe that you understand the consequences of you going home as well. You've also told me in very clear terms that you will kill yourself if you go home. And as such, I have a legal and moral obligation to not let you do that, okay? As the F2, or am I F1? As the F1, there's something that doctors can do called a Section 5.2 of the Mental Health Act. That means that we can detain you without your permission if we believe that you need to be admitted. So this is for up to 72 hours, and we will need an urgent psychiatric consult. Now, I'm very, very sorry that you don't feel the same way, but I'm going to go to my senior and I'm going to document everything that you've told me very clearly, with respects to the fact that you told me that you're going to go home and you kill yourself. Yeah, I'm really sorry about this. I know that's not what you want, but it's my professional medical opinion that you need to stay here with us and you need to be treated. Okay? How do you feel now? Do you have any questions for me?
Well, I just can't believe I just want to speak to one of your seniors. Clearly, it's not.
Yeah, that's absolutely no problem. I'll go and get a senior for you now. Okay, thank you very much.
Thank you. Thank you so much. That was great. Yeah.
Yeah, that's eating disorder patients.
Very well explained.
Okay, any questions on that?
No questions. I think it's just because you actually tried to convince her.
Yeah.
And you waited and you tried to give her all the consequences as well. And you also assessed her capacity indirectly by checking whether she actually understands what the consequences are, which I clearly do. And then you went on talking about the sectioning as well, and you talked about you will involve a senior. And you also told her, yes, if I want to speak to a senior, you can. So I think that was quite,
yeah.
That's good.
I forgot if I was F1 or F2.
Thank you. That was very good. I'm
just going to whack up it. Section 5.2. Just right there.
Just finish up the session, right? Yeah.
All right. So if there's any other questions, I mean, if you think of anything else after the session is completed, you're more than happy to send the questions in the group. Can I just ask everyone to please complete the feedback that I'm going to send in the group? And I really hope the session helped. So it was 2 sessions, discharge planning and the ethics portion.